Okay, hope you have a good lunch. And so now we are ready for the next session after this lunch break. And we will focus here on broad spectrum of presentations covering basic, translational, and clinical research. And from the very beginning, we are very honored to welcome Professor Shiv Singh, who is a professor in Department of Gastroenterology, Gastrointestinal Oncology, and Endocrinology at the University Medical Center Göttingen in Germany. He is, as well as all of our speakers, internationally recognized expert, but in this particular part for pancreatic cancer research, with a focus on tumor heterogeneity, therapy response, and molecular mechanisms driving resistance. So today he will give us his insights on latest advances and emerging mechanism of spatial heterogeneity driving therapy resistance in pancreatic cancer. Very happy to see you.
First of all, I'd like to thank the organizers, and I really feel honored to be here and talk about what we're doing. So I think you can hear me. It shouldn't be too loud here. So we heard a lot about early preventions and all the things. It's amazing to listen to the other side of the boat. And now my job is to convince you that how important to understand the mechanism which really happen in the tumor, and that how to tackle these things really and design a better therapy and all. And the special emphasis is a spatial heterogeneity. For those who are not familiar with heterogeneity, I'm just saying that looking from one angle, you look like a tumor. But in tumor, there are multiple tumor sites, multiple cell type. And this is what I'm going to cover today. So as you know that the pancreatic cancer remains a devastating disease, despite having tremendous therapeutic effort. And that is happening for more than 40 years, and there is a not clear path how to tackle, although there are new emerging technologies, therapies, which is happening in the world, and that somehow paving the path for the good therapeutic strategy right now. So the reason is the projection of pancreatic cancer remains high, and the mortality is very high at the moment. But look at the other side. At the same time, the lung cancer, colorectal cancer, and the prostate cancer prognosis significantly declined in the last couple of years, which is a very good news. And the thought-provoking question is that why pancreatic cancer remains getting high and high. One thing, as a biological perspective, that those cancer types tremendously improve the biomarker imaging and all those things. And also the funding was pretty good in that era, which did not happen in the pancreatic cancer. So the idea is that how to summarize everything and come back and tackle this situation. But the pancreatic cancer is a silent killer. Only 20% patients are lucky to diagnose very early who undergo resection, while 60% patients show metastatic at the time of diagnosis. So the only option to cure is therapy, palliative therapy. On the bright side, if you are borderline locally advanced tumor, you can be treated by neoadjuvant therapies. And later on, the tumors can be resected. But overall, if you look at this picture, which is quite horrible, despite having all this regimen, more than 75% patient experience tumor recurrence, and that's a reality for them. So I'm not a clinician, but I'm heavily involved from biology to translational biology. The recent findings show that there is a tumor-specific biological program, and that not happen only in the malignant or neoplastic compartment, but also in the microenvironment. So the crosstalk between these two systems can leverage a very dynamic changes and lead to recurrence, therapy resistant, and so on and so on. So comprehending this patient-specific tumor heterogeneity is the key to really understand the biology and the treatment and the precision. So why we are not able to tackle this heterogeneity question? So what happened in the last couple of years, they tried to implement genetic and the transcriptomic screening. To my best of knowledge, today, there are two clinically relevant subtypes. We should name it classical-like subtype and the basal-like subtypes. And the classical subtype patients, they do much better compared to the basal-like. And that's how it looks. So the basal means highly desmoplastic, dedifferentiated, while the classicals are glandular, well-differentiated tumors. And notably, there is a transcription factor GATA6, which people use as an early diagnostic or prognostic marker, as a biomarker. And high GATA6 exhibit chemotherapy response, while the low GATA6, that means it is not doing better. Or at least you can do, and that's why the transcription-based therapy today is probably one of the best shot. Okay, so, and based on those COMPASS trials that happened in 2016, and then there are multiple clinical trials across the globe initiated. And as you can name like PAS1, Purist, and SPAC6, that was in Germany in collaboration with Heidelberg and many other European countries. But it turned out to be, so this is a 2025 recent paper from Jennifer, who is a leading clinician from Canada. What they found that the transcription subtypes are the key prognostic, a factor which they can do very early as a basal-like in the classical and start treating them. And this is gemcitabine, paclitaxel, doing much better for the classical-like patient. But there's something going wrong when that happened to the basal-like. They do not do very good with the FOLFIRINOX. So the FOLFIRINOX is a very advanced treatment, and that do much better, leaving the toxicity, the second problem. Okay, so the biological perspective, if you look at this data, there is another layer of complexity. That's a very recent finding from that trial, and that shows that there are some patients who go under neoadjuvant therapy, they develop unfavorable outcome, which they name it, they develop persistence, recurrence, and resistance. So this is very complex biology. So I'm not taking it as a very negative thing. We need to understand what does it mean. So if you look under the microscope, it seems like those patients who do not do better, they have some kind of identity change. So they're not classical, neither basal, so they coexist. And that is directly associated with, there is an immune suppression program in that particular tumor. So what is that? And that question mark, if you have early prognostic subtype, that how are you going to treat this FOLFIRINOX or gemcitabine if the subtype is coexisting in 80% cases? So what is the first line hypothesis? And that happened not only in the resected, but also in the neoadjuvant. And that coexistence directly linked to poor clinical outcome, immunosuppression, and you name it, like TNF-alpha interferon gamma signatures are very high in that one. And that is something to do, again, with the tumor intrinsic transcriptional program based on those studies. And now I ask myself, what factors could be influencing the uniformity of subtype? If this is not stable, we are not going to implement the first-line therapy. And how do we implement therapy based on those transcriptional subtypes? So these are the questions I ask, my lab people ask. Back in 2021, these two papers came, one from our lab and the lab from Shalek, which is very famous from Harvard University, and both are talking the same thing. They say that the microenvironmental factors like TGF-beta is the one which probably influence the subtype switching back and forth, classical to the basal, basal to the classical. And we say that, well, there is a macrophages population that produce TNF-alpha, and that probably is also one of the key factors which doesn't make one type to one type. It changes back and forth here. So the question is that why those microenvironmental factors and subtype uniformity were not considered and implemented at that time. It's not like they were lazy. It basically is very complex biology to do everything at the same time. At least they started. So I just want to give a little bit on the data side. So what we found that the basal-like patient tumors, they have a lot of TNF-alpha. So you see red is TNF-alpha everywhere. But the classical glandular, well-differentiated tumors has very little bit on that. But we wonder on the biological for student and the postdoc who are really, you have to really deep dive that from where does this TNF-alpha come from? And that was our question from our PhD and postdoc. When they used the established classical and the basal cell line, they did not detect TNF-alpha in those human cell line. So the question was, from where? Then we implanted those tumors orthotopically, open the cavity, implant 1 million cells, and then you wait. We found a remarkable thing, that TNF-alpha was exclusively expressed in the basal-like orthotopic tumors, like basal-like patient tumors, but not in classical, or very less. But there's something popped out that the CD45 immune cells were highly enriched in those particular tumors. Only the connection with that one. So we thought, okay, well, still we want to wonder from where TNF come from, immune cells or the tumor cells. And it seems like when she did ELISA, Mengyu, we do not see human TNF-alpha, but we see murine TNF-alpha was significantly up, again suggesting that as those tumors are humanized, so the murine systemic system is providing TNF-alpha to feed that. Okay, so we wanted to validate this in the clinic, and then we have 27 patient specimen from Heidelberg, and Elisa Spinet, a very good friend of mine and an amazing scientist. She did all this cell isolation, immune, epithelial, and CAPS. So long story short, we found that TNF-alpha was exclusive on the immune system, not in the other compartment, confirming that TNF-alpha is not in the murine, not in the cell line, but also in the patient-specific manner coming from the immune cells here. But now I'm adding another layer of complexity, and don't hate me. So what we found that the TNF-alpha is also fluctuating. So these patients are resected R0. 46 out of 98 patients, they show heterogeneity in the TNF-alpha expression. So TNF is high, TNF is low. And then we wonder, what does it mean? So Barbara Grunwald from Canada, they did spatial profiling of every single immunosuppressive marker. And we found that when the TNF is high, they have low CD8 T cells, cytotoxic T cells, and inversely they have a high level of macrophages in that particular tumor site, what we are measuring here. So why it is important? There's a biological and a clinician perspective. So if you think of, there is no black and white, it's gray. So talking about reactive and deserted, so maybe I try to simplify that. It's a very heavy slide. So what she published that when they have a mixture of immune hot and immune cold tumor, that is directly associated with poor outcome in patient. And when you have one bright side, let's say white side and the black side, you are doing better. That was the finding. We thought, okay, let's do it. So we did TNF-alpha expression exactly in the same manner, in the same patient cohort, and we found that TNF-alpha was high in the reactive compartment and very low in the deserted, as you can see in the quantification on this data. Single dot present each patient, and the multiple dot represent 4 different tumor area from single patient. That's why these N numbers are pretty high here, suggesting that TNF is more reactive kind of atmosphere. But when you talk to any clinician about treating patient with anti-TNF-alpha, they will kill me. They say, what are you talking about that? TNF is always good, it's a necrosis factor. Anyway, so very hard to convince them. It is uncertain if high TNF levels are linked to subtypes. So going back to our initial question, is it really classical or basal or mixture? So the question is very simple. Does TNF play any role in mixing the subtype? Barbara data show that GATA6, if you remember, is a classical marker. When they have reactive and intermediate compartment, they have low GATA6 expression. No evidence of mixture. So we said, okay, take advantage. And what we found that we implanted that particular glandular tumor in the pancreas, as we did previously, and after tumor development, we treated with TNF-alpha intraperitoneally. And then we saw that TNF-treated tumors have poorly differentiated ACA basal-like phenotype, as you can see in the quantification, and there is a gain of keratin 81, which is a basal-like marker. So the mystery of TNF-alpha as a tumor protective is resolved. Actually, at least in the preclinical model, it is not the case. Actually, it is inducing more aggressive tumor. We again came with the question that, what is the mechanism of this subtype of existence? And what controls this lineage transcriptional switch, as we are talking about the transcription subtype. Okay. So we did simple approach. Those tumors, TNF-treated tumors, we did bulk RNA sequencing, and then we measured tumor-specific program and the stroma-specific program. Easy. And we found that the TNF-alpha, so a simplified version, when we treat with TNF-alpha, you see all those transcription factors, and those who are aware of transcription factors, they really control the lineage plasticity. And those 5 genes are very important to maintain identity of a particular tumor type, and they significantly went down, and simultaneously we see that the basal-like programs are going up. It's a very plastic system, we see that here. So then we dig on what June B actually doing, because June B was one of the factor, June B was one of the factor on top. So we tried to dig on, and we found that, or somehow we linked that the June B maintained the differentiation, the development of those particular tumor type. And then we used a surrogate marker, GATA6, to really identify that does June B does exactly the same thing what GATA does, and it turned out to be in our hospital. We took the resected pancreatic tumors, and there are beautiful co-localization of June B and GATA in those particular tumor type. Again, confirming that they are doing probably the same thing. So then how does it really matter? If June B is high, what does it mean actually? So linking the mechanism why it is important, so we found that actually June B, so this is a simple ATAC-seq and ChIP-seq data. So basically you pull down the protein and look where June B bound on enhancer and promoters of the whole genome actually. And again, very simplified version. It's very complex picture, so I'm sorry about that. What TNF does, or what June B does actually, it really represses all the inflammatory pathway. And these inflammatory pathways are bad actually. So in summary, I created a model. It seems like June B, GATA6, and there is another HDAC transcription epigenetic machineries. They act together and try to repress all the bad inflammatory cytokine in the cell system, which is good actually. So they try to restrict all the inflammatory systematic reaction and try to prevent it. But again, I mean, actually a thought-provoking question. If there's one patient who got pancreatic cancer, and I believe they have both, all the subtypes are there. So sometimes they are fighting each other to controlling, hey, you don't come or you come. And that was the thing we tried to understand that, what is going on. So before we jump on to really dig into deep, we thought, okay, what does it mean? If they have June B repressed signatures, so again, simplify these questions. When those signatures are up, prognosis is poor. And let's say if these teams are working properly and doing their job, the patients are doing better. And this is 580 patients, so it's not 100 patients, I'm talking about that. So it gives a transcriptional signature, it has a meaning of that. So they have some role in a good way, actually. So basically we silenced June B, and we found that there is upregulation of those individual markers, which link to more unfavorable outcome. And again, summarizing that, so June B in this glandular compartment try to repress C June and C June. So C June and June B, they are siblings, they are relatives. They belong to the same family member, but they don't like each other. So June B, if it exists here, they say their sibling, don't come here. So basically what it does, it directly represses. And why C June is important? Because that controls this whole unfavorable cascade leading to macrophage recruitment and then TNF-alpha pathway. So what C June does, C June directly controls CCL2, which is a chemokine, and that goes to the macrophages because it has CCR receptor, and CCL2 bind to CCCR, and that brings TNF-alpha all the time, and that makes all the time aggression and plasticity related things. But June B was not homogeneous either. June B is also fluctuating in those patients, and 34 out of 100 patients, they show spatial heterogeneity. So nothing is black and white. They always fluctuate for some reason. And I think the idea was, you shouldn't consider one subtype. You have to also consider what is going on in the mechanistic level. What are the factors? So the clinicians, I respect them a lot. So sometimes you see that, okay, let's do clinical trials. Throw all the medicine, but it turned out to be the neoadjuvant throwing is doing unfavorable things. So why? So those are the questions I'm trying to summarize here. So Now, as we know that the loss of JunB is important to restrict all the bad things happening. So the question was, does it also do sort of coexistence of, which is poor outcome? So what we did, we created a very novel model. So we used c-Jun, which we already know induces CCL2 and TNF-alpha in the microenvironment. So we overexpressed c-Jun in those tumors, implanted, and then we did nothing, we just waited. And this is done by Lucas. It's an amazing postdoc. What he analyzed that, a coexistence. So when the c-Jun area is high, the macrophage is recruiting in that area. And in the JunB, which is an orthotopic model, they have low. So basically what happened that c-Jun recruit all the time the CCL2, TNF macrophages, as you can see here, and the AMP2 macrophages, and when the JunB is far, it doesn't really touch that area. So all I'm saying that in one tumor, if there is something going wrong, it is going to influence your neighbor. It invade. The theory was, that's one tumor and that's one tumor. This is not true. Whether pancreatitis, inflammation, alcohol, whatever happening, it is not classical. So you have to measure that. There is a continuum of things going on which pinching the other one. And this is what we try to measure in that particular mouse model. And it turned out to be, yes, what they do that, for some reason, if they have a high macrophages, they have TNF-alpha and they try to push all the time to more coexistence and eventually leading to more basal-like and aggressive tumor and metastatic subtype. Okay, well, this is all preclinical model, beautiful done. And now our centers, so what we do in our lab, we have, I think, more than 160 resected organoid and also patient-derived cell line. And all the time we implement those on the flank and try to generate a large data set that we can recapitulate not only my lab finding and other people finding. So, and then we do all the time genomic sequencing of those patient material to know that if there is a vulnerability to have a KRAS inhibitor or BRAF inhibitor and let's say other vulnerable target. So this is the platform we try to do that. And then we went back and check, what if those patients are borderline and locally advanced? And then they have neoadjuvant therapy. Does neoadjuvant therapy doing the same thing? And what we found that after neo, which was FOLFIRINOX, and this patient is 78 years old, is not mentioned here. That's why I want to show the online thing here. So what we found that there is a loss of those JunB and GATA6 markers, which is very important to maintain the integrity of the cell system, which is somehow losing. And that was linked to more macrophages recruitment in that particular area. At this point, I'm not saying it's good or bad, I'm just saying what we observe. Whether macrophages were helping, which I don't think so. So we are waiting for that adjuvant therapy in this patient, and then we'll get the follow-up and see what exactly happened. He's alive. Okay, so, and then we thought, okay, well, this is a patient perspective. It's sometimes very hard to get, and the patient consent, the family doesn't allow us to do autopsy, and that's why we simply try to get biopsies somehow from the surgeons. But at the same time, we try to understand the biology. So there is another case that was R0 resection, no therapy. We made patient-derived organoid, and then we try to understand how conservative this model is. Do we see a lot of JunB and GATA6, which is a classical marker? And yes, so they have some patient specimen, they have a hyperexpression of the tumors, and they look so beautiful. They look glandular, and then well-differentiated tumors. So we treated TNF-alpha for a long time, tried to mimic what maybe neoadjuvant therapy is doing. More inflammation, TNF is high, interferon is high. Is that pushing the boundary? So we tried to do this for a long time, 7 days until 21 days. Nothing happened in the early, but later on, you see there is a JunB, which is a good marker, going down, and the c-Jun rising up. And together we also see CXCL10. It's a very debatable. CXCL10 also recruit T cells. So we don't know yet. I'm very cautious speaking here. So what we see that this plasticity remains same in the very highly organized organoid system from a resected patient here. Okay, so what is the endpoint? What can we do with this analysis? I mean, what is how can we really implement those things in understanding and treatment? So we did a very aggressive model, KPC Black 6. If you implant the tumors, they just live 21 days. So we treated with anti-TNF-alpha monotherapy with antibody and gemcitabine, which is a first-line chemotherapy. And we see there is a very nice improvement in the survival in this mouse model, leading to more cytotoxic T cells and decline in the macrophages, at least both in the preclinical models. So I just want to summarize what is happening that the tumors are very plastic. If you have 7, 8 clinical trials going on in classical, you are going to treat tomorrow with modified FOLFIRINOX, make sure that they remain same until the second and the third line, which is probably not the case. So we need to understand very early, so we try to do that, blood plasma isolation and check the TNF-alpha level along with the CA99 carbohydrate antigen. So these are our plan here. So I tried to push it, and we had a hard time because even having Comprehensive Cancer Center, I spoke to her yesterday that if you have a neoadjuvant therapy, and those patients sometimes don't allow you to try a new therapy. So we thought, okay, maybe there are some anti-TNF therapy going in the lung cancer patient, also in US, and they have like stage 2 and stage 3, so maybe we can somehow mimic and try to implement with those patients, pancreatic cancer patients. So I hope very much which are probably going to happen soon. And this is the last slide, I think. So what I also want to do that, because this meeting is not about also just basic science. We, as a biologist, we try to implement all this finding in the clinical thing. So we just got this paper out from Laura in our lab, and she identified that palbociclib, which is widely used in breast cancer and pancreatic cancer, those inhibitors can also kill this one of the most arrogant protein, which is P53, this particular mutant. And she found that if you have this mutation, and there is no inhibitor if you take my note, to my knowledge, that can kill this protein. So we identified this protein, this inhibitor, clinical inhibitor, FDA approved, can kill that protein. Simultaneously, we found that killing is not all. They develop resistance, and that's another thing. And this resistant mechanism is coming from MAP kinase pathway. And then what we did, we combined MAP kinase ERK inhibitor, palbo plus trametinib, and then we try to say that, okay, these inhibitors are working together with this one and not that one. So now we are recruiting, and this is a retrospective study because those patients who have KRAS mutation and CDKN2A, they're already going under treatment. So we're just adding a layer. Can you please check for that mutation? And we are also doing. So Comprehensive Cancer Center is very useful. I think at least you can test your hypothesis and implement those findings. Okay, this is from yesterday. So what I try to convince, and from the castle, I love that. I mean, and thank you so much for all the tours, actually. This is very, very important. So, you know, like in your first experiment, you guys find that there's much more to do in that one. In the second, 2008, you're leading to a gold and the silver coin, right? So I'm saying that when we have a KRAS, was 20 years ago, and now we have 2025, we have to dig deeper. And the deeper you dip, more you know. And you get the surprises, actually. This is my thing. And those people, I presented those students, and now they are amazing people, postdoc, and their study and also funding to German Cancer Foundation, which was a foundational, not only for my career, but also the whole lab and the other funding agency and my lab people and those collaborators. So thank you very much. I'm open to take any questions if you have. And I hope I'm in time. Oh.
So are there any questions for this interesting topic? Okay.
Thank you very much. That was really great and inspirational. My question is, there are many different tumor types that contain desmoplastic component. Do you think that similar mechanism can apply to different tumors which have mixed desmoplasia with the glandular type.
So you're talking about non-pancreatic cancer?
Yes.
Yes, probably. I think breast cancer, colon cancer is one of the key examples, I think. They have same thing. But there is something special in pancreatic cancer because they are highly desmoplastic, correct me if I'm wrong. And I think this is what they're switching all the time back and forth. And we are not covering yet everything. There are caps involved in this thing. But the bottom line is that we need to understand every aspect. It's not just living and moving and now treating the patient. I don't think it will work out. And yeah, sorry for this. Anyway.
Any more question or yes?
Thank you very much again for a nice presentation. My question is if the different treatment like gemcitabine or oxaliplatin-based therapy will change differently this microenvironment.
Very good point. Actually, excellent question. It does. So even I don't know whether I should say or not, I was in France right now for the grant review. And I see that a lot of study coming that, in fact, gemcitabine, nab-paclitaxel, and that's what Barbara also showed that. It induces more calf-like phenotype, more deserted. So the therapies are doing something. I would not say therapy is doing something. The cells are adapt to the therapy, and they make a fibrotic network to prevent either immune cells not reaching to this territory. So I'm saying that maybe we have to work on that part too. So definitely, I would say it's a secondary resistance. It's adaptation. Therapies are doing better for sure, but the other side is doing something wrong, and that probably we have a little bit of understanding. And I think this is the era. KRAS inhibitor is monotherapy. Now they're combining with immune therapy. And now they're combining with probably anti-fibrotic agent. So the tumors are very smart, I think. Unfortunately, yeah.
Okay, so I guess there are no questions, maybe later. And we will keep on going, and we will stay in this pancreatic cancer field. So, ladies and gentlemen, please welcome here Professor Bruno Sainz. He's coming from Cells Moriale Institute for Biomedical Research, and he is a coordinator of Area 3 Cancer at the Ramon Cajal Institute for Health Research. He has a broad expertise in immunology, virology, oncology, and he's focusing on developing innovative therapeutic strategies using nanoparticles, and we will hear today his presentation about pancreatic cancer.
Thank you. Thank you very much for the introduction. First of all, I think most important to thank the organizers. Elena, thank you for the personal invitation and the hospitalities we've received these past 2 days. Excellent. I have to say that while this session has been great, the castle visit yesterday was spectacular. So thank you, as you saw in some of the pictures. So I'm glad that she did an excellent introduction on pancreatic cancer. That gives me a bit more time to talk a little bit more about the science. Just want to point out here that I have this double affiliation. So we have the Spanish Research Council in Spain, which is known as the CSIC, which is where I'm primarily affiliated with. And there we have a very basic laboratory. We work primarily on cancer stem cells and pancreatic cancer, and also try to understand the tumor microenvironment, macrophages in particular. So again, Sheep, thank you for the introduction. You've done my job for me. And then we also have another group at the hospital. So we have research institutes in Spain, but then we also have research institutes that are affiliated with hospitals. And I think this is a fantastic organization. We heard a little bit about this this morning from Eva about cancer centers, where research is so important, and that connection. Although we can sometimes have it with a hospital and a research institute being far apart, but when they're together, it makes it that much easier. So distance really does make a difference. Luckily, the hospital is just right across the street, so it makes my job a lot easier. And I have a fantastic group at the hospital. This group is led by Julie Earle. You'll see her in the acknowledgement slide. So here we're really trying to get an understanding of biomarkers and how we can do personalized cancer research. So two different approaches and two different laboratories, but we learn from each other. And I think this is also very, very encouraging. So with that, I'll stop talking about myself and talk a little bit more about pancreatic cancer. As Shiv already pointed out, we know it's a malignant neoplasm of the external pancreas. It's the fourth most frequent cause of cancer-related death to date. It's probably one of the most deadliest forms of cancer, with a 5-year survival rate of less than 12 to 13%, depending on the country, the continent, etc. And that makes a difference. And this is primarily due to these statistics, the lack of early symptoms. So these patients really don't have early symptoms. And the symptoms they do have, they reflect on post-diagnosis, tend to be symptoms we have very common, aches, pains, a loss of weight, etc. We saw this a lot with post-COVID. Patients were losing weight, but they just thought that was natural because of the anxiety, the stress, being confined, diets that they were doing, or eating better or eating worse during COVID. So there were a lot of patients that were experiencing symptoms during this time that went a bit undiagnosed. But this is really, as she mentioned, a silent killer. The tumor does not present symptoms, and this is probably one of our greatest battles, because if it doesn't present symptoms, then the patients don't go to the clinic, the patients don't undergo screening approaches, biomarkers aren't detected early enough. So this really makes the medical oncologist's job quite difficult. And so what we really need are reliable diagnostic markers to detect pancreatic cancer early. And this is primarily the work that Julie Earle is doing in the laboratory. Obviously, we can't do a diagnostic screen on the whole population, but there are patients we can learn from, patients with familial pancreatic cancer, patients that are high, what we can pancreatic cancer, for example, have BRCA1 or certain somatic mutations. These patients have a higher propensity or probability of developing pancreatic cancer. Familial pancreatic cancer, which means if you have 2 first-degree relatives that have had pancreatic cancer, your probability to develop cancer is much higher. So there's a fantastic consortium in the United States called PROCEED, which is led by Dan Simone, where they're trying to thousands and thousands and thousands of patients that are considered high risk or familial cancer patients, try to identify these biomarkers. So if you're interested in early detection, check out the PROCEED website. It's quite informative, and it's spectacular what they're doing. So unfortunately, we don't have these reliable diagnostic biomarkers to detect pancreatic cancer. We tend to then, well, we normally detect pancreatic cancer at very late stages when the patient already has metastases. Keep in mind that for cancer in general, the majority of patients don't die from the primary tumor, they die from metastatic disease. So this is really important. This is the patient population that we need to treat now. Hopefully, in time, we will be able to detect pancreatic cancer earlier and our patient population will change. But really, these are the ones that the medical oncologists really want to treat. We have resectable patients, as she had mentioned, borderline patients, but the majority of our patients are the ones now with metastatic disease. So we have to try to understand if we can't, targeting the primary tumor is great, but can we target the metastases and see whether or not we can have an effect here and prolong the life of these patients? So unfortunately, and to sum it up, pancreatic tumors are highly resistant to chemotherapy and radiotherapy, and therapeutic options do not really cure, or in very, very few cases, cure pancreatic cancer. The majority, typically what we can give patients is anywhere from 6 to 12 months overall survival with the current chemotherapeutic regimens that we have in the clinic. And if that wasn't bad enough, and if you can see here the statistics for the United States in 2024, small number of patients diagnosed with pancreatic cancer, but the overall survival, 77% of these patients did not survive their diagnosis. So we really need to better understand this tumor. We need to develop better biomarkers, we need to develop better screening approaches, and we need to develop better therapeutics to treat pancreatic cancer. So as she mentioned, it's a very heterogeneous tumor. It's probably one of the most heterogeneous tumors in my opinion, and with no disrespect to other people that work on other tumor entities. It's extremely difficult to understand this tumor, and it's not because we have not invested time and research in understanding pancreatic cancer. There are fantastic researchers all across the world. In fact, some of the first genetically engineered mouse models work for pancreatic cancer. So this is not a tumor that's been neglected at by the part of the research or the research field. It's a tumor that's really been studied quite extensively, but we still do not understand it. And we're constantly learning a lot about pancreatic cancer, and we still don't understand this tumor, but we are making advances. So not all news is bad news. We are definitely making advances. And so if you look at the tumor, in my laboratory, we primarily study cancer stem cells. We believe this is the root of the tumor. These are the cells that give rise to all the other tumor cells present within the tumor. So these would be the bulk tumor cells and the cancer stem cells. Keep in mind that pancreatic cancer is very slightly populated with neoplastic cells. About 90 to 95% of the tumor is stroma. The rest of the tumor are pancreatic tumor cells. So you have here the components of the stroma. We have cancer-associated fibroblasts. We have very particular to pancreatic cancer and also to hepatocellular carcinoma would be stellate cells. So in the pancreas, we have pancreatic stellate cells. We have immune cells, which range from anywhere from neutrophils to MDSCs, and also macrophages, where very important immune cells infiltrate. We have, of course, secreted factors, and of course, we have the extracellular matrix. And all of these components separately have a role within the tumor, but as she mentioned, there's a lot of communication between them. So all these cells communicate with one another. They communicate with the tumor cells in particular. It creates a very complex and dynamic tumor microenvironment. And this dynamic microenvironment can be very different where we see the tumor. If we analyze the tumor here, 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 etc., we can see there are shifts and differences in the tumor microenvironment. So what we see in one biopsy or what we see in one piece of tumor that a pathologist will give us may not be representative of the entire tumor. And we always need to keep that in mind. That's why we can't really rely on just one organoid model or one PDX model. We really need to analyze a number of samples to have a better, a complete picture of what's going on. So in the tumor microenvironment, we're being particularly focused on tumor-associated macrophages. As you can see here in this histology, this is a typical marker for tumor-associated macrophages, CD163. It's one of the predominant immune cell infiltrates present within the tumor. Neutrophils are also very important, or infiltrate very well into pancreatic tumor. So for the longest time, as Ashif has mentioned, and this varies from tumor to tumor, but tumor-associated macrophages clearly play an important role. And there's communication between the tumor-associated macrophages and the cancer stem cells and the cancer cells. And we believe a large part of this communication is due to this inherent relationship that they have with one another. Cancer stem cells like tumor-associated macrophages. Tumor-associated macrophages basically become the slaves of the cancer cells, secreting factors that promote the proliferation of these cells. And for the longest time, we've been studying tumor-associated macrophages, we probably now for about 15 years in the laboratory. It wasn't very much in vogue about 10, 15 years ago. Now it's become very popular to try to study the immune infiltrates in pancreatic cancer, and in particular tumor-associated macrophages. They secrete factors which create the cirrhosis we see both in the tumor and in the metastases. And this very wonderful study from Patrick Nicol very early in 2017 really showed that TAMs are important for metastasis. What they did here was, in the KPC model, which is a model that develops a mirroring model that develops pancreatic cancer, they eliminate macrophages. There's no effect on the primary tumor, but metastasis decrease. So that really gave us the first indication that if we want to help patients with advanced disease, and we really want to target metastases, maybe targeting macrophages is the way to go. So TAMs contribute to tumor progression. They confer resistance to chemotherapeutics. They metastasis really shown for the first time by this study, and they facilitate tumor immune evasion and promote an anti-tumor response within the tumor. These are general concepts. As you saw earlier, tumors are very different from patient to patient, so this may not be applicable, obviously, to each patient individually, but in general, this is what we believe. And we believe that a lot of this is via so macrophages and also the tumor cells are secreting factors, creating this very milieu of factors within the tumor microenvironment that create this very complex crosstalk. So we want to disrupt this crosstalk, which has been the goal. So again, we're really interested in metastatic dissemination. We know that the pancreatic tumor cells secrete factors which reach the liver. This activates the macrophages in the liver, in particular the Kupffer cells. These Kupffer cells, here we have TGF-beta, which is a main player here, together with hepatic stellate cells. Start secreting factors, which are induced also by the TGF-beta coming from the tumor-associated or the macrophages within the liver. This creates a very nice environment so that when the tumor cells finally reach the liver, the environment is perfect for them to now establish these micro and macro metastases. So a lot of this binds, so here's a very important factor. It activates downstream activation, SMAD3, for example, it's phosphorylation, which activates a number of downstream mechanisms that are involved in fibrotic reorganization, fibrosis, etc. Also plays in tumor cells. And there are inhibitors of these pathways. These inhibitors have not been very successful in the clinic, which doesn't mean that we can't reuse them or think of a better way to perhaps incorporate them into a clinical therapeutic approach. So this was the birth of this project. So this is called PediPac. This is a URNanomed 3 project. We started probably about 6 years ago. It's now completed. And the postdoc in my laboratory, Adrian Parente, was the leader of this project. The idea was that metastasis is really what we want to target. We know that macrophages are very important in this metastatic cascade, this pro-metastatic niche reprogramming, creating this environment so that when the tumor cells reach the liver, they have the perfect environment to create these micrometastases. And we believe that TGF-beta here is very important in this process. So the idea of this project was to basically turn these macrophages that support macro or micrometastases back into M1 macrophages. These would be the pro-tumor, these would be anti-tumor macrophages, and we believe that this re-education of macrophages could then potentially inhibit or reduce metastases. And there are a number of ways we could have attacked this. Obviously, URNanomed, this project was very focused on nanomedicine, nanotechnology. So our idea here was to try to use nanoemulsions or nanosystems to try to reconvert or re-educate macrophages. So this is a very simplistic way of thinking about it. So sometimes it's easier, and sometimes you have fantastic results with simple approaches, and sometimes you have failures. So I will show you some in-between results. Not a complete win, but not, of course, not a failure at all. So we teamed up with, in this project with Maria Fuentes. She was the coordinator of our PediPac project. And she's an expert on nanoemulsions. We've been working for many years to try to develop different types of ways of creating nanoemulsions or nanoparticles. She did an easy way of lipids and ethanol. Just a quick injection creates spontaneous these nanoemulsions, where you can also encapsulate drugs within them. And here, for example, these specific types of nanoemulsions were coated in vitamin E, sphingomyelin. You can add drugs, antibodies, and proteins. And in this case, for example, we wanted to encapsulate the TGF-beta inhibitor, which we refer to in this presentation as LY215. So initially we studied a number of different types of nanoemulsions. The one I showed you with vitamin E, sphingomyelin was the best one. Of course, we went into this project trying to figure out which is the best type of nanoemulsion to use. Here we use bone marrow-derived macrophages directly from the bone marrow of mice. And you can see here a very simple experiment initially that there are some nanoemulsions that have very low to no toxicity. And here we wanted to see whether or not they could repolarize macrophages from the M2 pro-tumor state to an M1 anti-tumor state. And so we can create macrophages here with different, basically adding different types of cytokines. And you can see here that there were basically 2 of the nanoemulsions by themselves without the LY inhibitor that were able to reprogram macrophages back to an M1-like state. So it's sort of between an M2 and M1, not completely M1, but a very nice difference between the 2. So we chose to work further with this nanoemulsion. The nanoemulsion, especially when we cover the lipids with top fluor, which is just a fluorescence protein, you can see that they enter very well into the bone marrow-derived macrophages. You can see here that the 100% of the bone marrow-derived macrophages have taken up the nanoemulsion with top fluor. And then when we inject mice with particles with the top fluor and look for macrophages in the liver that have taken up the nanoemulsion, here we use CD45, CD11B, and F480 as our markers to identify liver macrophages. You can see that as early as 24 hours after injection, we can see that the macrophages are already starting to eat or take up these nanoemulsions. Macrophages love to eat. We know that from phagocytosis, so they're wonderful recipients for nanotechnology. Anything you inject in circulation will go to the liver. There are macrophages in the liver, so it's a fantastic way to introduce nanoparticles. One of the things we've in nanotechnology is usually that one of the downsides is that the majority of your nanoparticles go to the liver. But if that's your target organ, it's a fantastic approach then. So with this project, what we were able to do is then use the sphingomyelin vitamin E nanoemulsions. We incorporated the inhibitor TGF-beta, and we did a number of in vivo experiments. I'll just show you a few examples here. For the sake of time, so we established these orthotopic implant models, which Shiva mentioned earlier, that we take tumor cells that are derived from these genetically engineered mouse models that develop pancreatic cancer. You can inject them into the pancreas of the mice. We inject very few cells, about anywhere from 1,000 to 2,000 cells. These mice will survive usually about 35 days. Post-injection, we initiate the treatment, and what we're able to see here, these are the control mice, 21, 28, and 35 days. Post-injection, you can see the formation of the tumor, also the peritoneal and metastases. However, the mice treated with the sphingomyelin vitamin E and LY inhibitors have reduced tumor burden. This is just a primary tumor. We're not talking about the metastases. And when we analyze the pancreas of what we see in the pancreas of the mice where we're treated with the nanoparticles or nanoemulsions, we have a more healthy pancreas and not a complete takeover of the tumor cells within the pancreas. So this is not what we expected. We really didn't expect anything at the primary tumor level. We were really interested in this, but this was a very nice surprise. Also, the weight of the time and the overall data, you can see that the weight of the tumor is much lower with the nanoemulsion treatment. If we look at the liver of these mice, so what we were able to see is that the macrophage infiltration, so these mice did not develop metastases because it's a very, very fast process. It doesn't really give time for these mice to develop metastases. But what we do see is the infiltration of macrophages, if you look at the control line, in the livers of these mice. So they really are trying to prime that liver to be ready for metastases to occur. But when we use the nanoemulsion, what we do see is a drop or reduction in infiltration, and in particular the M2 macrophages. And so to look at more of a metastatic model, what we can do is inject tumor cells straight into the spleen. So from the spleen, there's communication with the liver, and then so we can inject cells in the spleen and go to the liver and form these metastases. So we did this similar experiment where we injected tumor cells into the spleen and then looked for metastases or the accumulation of tumor cells within the liver. Here we use KPC-derived cells, which are labeled with M-cherry to allow us to better detect those cells. We did intraplatelet injection, and the next day started the treatment, and at 18 days post-implantation looked at the livers. And we're able to see in livers in the control mice, you see very nicely these macrometastases, also their micrometastases by histology. You can look at the level of M-cherries, that actually see about a 50% reduction in the number of tumor cells that are present in the livers of the mice that are treated. If you look at just, this is sort of an indirect marker for the presence of the cells within the tumor, but what we really saw was also a nice reduction in M2 macrophages. But this is the most surprising effect that we see here, that we're just with immediately after intraplatelet injection, we're able to see this downregulation. And then we wanted to translate this to the human setting, because everything we've done so far has been with mice. So we have we created these 3D human spheroids where we have PANC1 cells or in GFP, CAFs, which are in M-cherry macrophages, which are unmarked here. We create these spheroids, we treat them with the nanoparticles, and also we inject them right into the pancreas of the mice, and we look days post-implantation to see the effect both of the primary tumor development and also in the pancreas and the liver. And what we see here is that with control versus the nanoemulsion treated, we see a reduction in primary tumor burden. We also see a reduction in GFP, amount of GFP cells within the pancreas, because positive, you can see here the differences in tumor burden with treatment versus the non-nanoemulsion treatment. In the liver, we also saw a reduction in GFP positive cells, and here's this human GAPDH, which is a direct indication of tumor cells within the liver, so again, a reduction. So this is obviously taking this nanotechnology to clinic would be quite difficult, but Maria is working on improving both the formulation, the processing, and the development of new nanoparticles, which we're testing currently, and which in fact have a much better efficacy in vivo and in vitro than what we've seen with this first generation nanoparticles. So we have hope that these nanoparticles may one day reach the clinic and reach patients. And so just in summary, if I think I'm fine on time. Yes, perfect. So again, we've been studying macrophages for about 15 years in the laboratory. They're a very interesting dynamic plastic cell. They obviously have pro-inflammatory and pro-phagocytic functions. They are there, and we've also always thought of macrophages as something good. They should be able to eat tumor cells. They should be able to eat cells that are infected with bacteria or infected with viruses. So in theory, they are a good first line of defense against neoplastic or tumor formation. But they don't. They're not very good at phagocytosing tumor cells, in particular cancer stem cells. Obviously, I don't really talk about cancer stem cells today. Just go home thinking that cancer stem cells are bad and we need to attack them and eliminate them. They are the root of the tumor. But again, these macrophages are incapable of destroying or phagocytosing cancer stem cells. And there are many reasons for this. They express a number of receptors on their cell surface. For example, CD47. CD47 is a delivery signal. So by expressing CD47, macrophages see them and say, oh, I'm not going to eat you, I'm not going to phagocytose you, I'm going to leave you alone. So this allows the cancer stem cell to escape this initial phagocytosis. And therefore, they live together. The macrophages are there, the cancer stem cells are there, and now they can start communicating. And what the cancer, we just recently also identified another protein that cancer stem cells express, PGLERP1, on their cell surface. And it's interesting because also it plays an important role in the TNF-alpha signaling pathway. So Juan Carlos in the laboratory, who was a PhD student, now is a postdoc in Mariano Barrace's laboratory, also showed that this protein expressed on cancer stem cells is a way also to evade macrophage phagocytosis. So this is what we call immune evasion within the tumor, and this therefore allows the cancer cells and the cancer stem cells to start secreting other factors that can play a role in re-educate these macrophages. For example, TGF-beta, which binds to the TGF-beta receptor, and this causes a plastic or dynamic change type switch in macrophages. They go from an M1 phenotype to what we call an M2 phenotype. In the macrophage world, we don't like M1, M2, so just remember that these are pro-inflammatory anti-tumor, and these are pro-tumor alternatively activated macrophages. And so now they're different, they express different markers, and now these two cells live harmoniously together. And the tumor-associated macrophages start secreting many factors that we've discovered over the course of years. For example, L37, ISG15, which is involved in the interferon response. Pancreatic tumors are known for having a very high innate interferon alpha-beta signature. They also excrete factors like oncostatin M, which can bind to the oncostatin receptor on the cell surface. 14337, which actually is very important for these cancer cells or to evade chemotherapy resistance. So all this communication, there's much more behind this. We've only discovered a number of pathways. Increase the stemness, the epithelial to mesenchymal transition, chemoresistance, and the migration of these tumor cells. And also, it plays a very important role in remodulating the extracellular matrix. So all of this communication and, for example, the excretion of these factors also act on the extracellular matrix, creating these highways. They're much better for the tumor cells and the macrophages to escape the tumor. In fact, what we find is that the macrophage and the tumor cells escape together. They actually create this fusion between them, and they escape together within circulation and then mediate metastasis. And we've been trying to attack all of these pathways via different approaches, chemically, nanoparticles, etc. And this is quite interesting here, this macrophage cancer stem cell fusion. What we can see here is that when we look in circulating and liquid biopsies from patients, and we use a marker to identify cells that are CD163 positive, so this is a marker for tumor-associated macrophages, and EpCAM, which is a marker for tumor cells, what we can find in metastatic patients, they have many of these cells that mark both these markers. So what we think is that there's a fusion between these two cells which facilitate metastases. And again, our goal right now is to improve this nanotechnology via nanoemulsions to turn TAMs, or tumor-associated macrophages, into a more anti-tumor pro-phagocytic TAM or macrophage-like subset, which can hopefully reduce metastatic burden, which is our goal. So with that, I will end. This is the BioPack group, so this is both the clinical and the non-clinical members of the laboratory. Here is Julie, who I mentioned earlier, who leads the laboratory at the Hospital Ramon y Cajal, Adrian, who just presented or done all of this work. And of course, thank the funding sources and Maria de la Fuente, who was the leader of the Euro Nanomed project. And with that, thank you for your attention. I'd be happy to take any questions, or we can talk later at the coffee break if we're short on time. Thank you.
Thank you very much, Bruno, for a very interesting presentation. And if there are any questions, maybe now or maybe later, if somebody wants to ask. So maybe, yeah, by the coffee. Yes, so thank you very much. And now we will continue with kind of, I would say, fashion topic, if I can say like this, about using of AI in oncology. And here I will present and welcome Associate Professor Michal Kovač, who is also a Vice Dean for Science and Research at the Faculty of Informatics and Information Technologies. He leads the BrainWorks research group focusing on AI application in precision oncology, and his research interests include personalized oncology, therapeutic targets prediction using big data analysis, and then AI and visualization of high-dimensional data. So please welcome Associate Professor Michal Kovač with his presentation.
Good afternoon, ladies and gents, and thanks, Sonia, for a very kind introduction. Thank you, Jan and Martin, for actually bringing me here. So I can talk a little bit about AI, and I guess I'm the only computer scientist in this room, so I will take this a little bit lighter, just focusing on things which we can do with AI and not pretty much how things are done internally. So, in principle, what we are trying to do, we are trying to do in silico therapeutics. So, based on big data analysis, we are trying to predict to which drug a cancer or specific cancer type will respond to. I mean, obviously, there are many ways how we can approach this subject. There are classical ways where you have large association studies, where you have large cohort of patients and associate treatment based on, I don't know, some biological merit or something. In the modern era, especially when I was in Basel, where I spent 14 years of my life, well, we try to do a little bit modern approach where you have patient-derived 3D cultures and then you try to cultivate them with different drugs and see what works best on patients, and then you give the drug back to the patient. In the meantime, as an AI practitioner, we're trying to do a different approach. So we try to do something which we call in silico therapeutics. In silico mean by computer simulation as opposed to classical in vitro, in situ, in terms that you normally use in biology. So in the age of AI, we basically build something which we called models, and then we filled models with something which we called features. And all about these features, I will start talking first, so you get a little bit of flavor what we actually tried to feed this model with. So what is a feature in ML, in machine learning? So a feature is anything that you can quantify, or anything that you can extract from any types of data. It can be a DNA mutation, it can be a string of text, it can be a specific pattern of mutations like histogram or a picture, which you can somehow turn into data. And these can be then fed into the models. I mean, basically they are coming in two flavors. One is what we call the rectangular data, which is, I mean, this is a fancy example from a nice BBC a course which is called A History of the Humans in Hundreds Objects. So this is a Babylonian table probably one of the first rectangular data that we have today, and it's basically a salary record. So it's a salary record for public workers, some public construction works in beer. So the beer is this pointed jar, and then you have these crescents and these imprints which tells how much a worker should get, and the worker sign is actually this. Well, I'm not sure what to name it, but it should be a hat about the bowl of porridge. So basically, a rectangular data has features in columns and then observations in rows. Another types of features come from data which we call unstructured, and that's basically every type of text. So text is a typical unstructured data, but you have syllables which you can turn into words, words you can turn into sentences, sentences into paragraphs, so you can give structure also to unstructured data. And it goes similarly with DNA, so you have bases, so you don't have 20x alphabet, you have just alphabet of 4 that you can turn into strings of DNA sequences, those you can turn into domains, then you have inter-exon structure, then you have high order structure of human genome, etc. So basically you have these kind of all features which you would like to associate with some sort of therapy at the end. So this is what we software engineers called a map, which is read from right to left. So basically you want to map therapy into some specific cancer type, given a set of features for each DNA variant that you can detect by genome sequences of cancer genome. So basically this is how it works, and now let's see what we can do with the modeling of these features. So basically the first thing that we started doing it during my first years at the University of Oxford, where I was a postdoc and then I was a student at the same time, was to use the features to annotate somatic mutations from early cancer genome sequencing projects. And then we wanted to associate specific mutations with predisposition to that cancer type. So roughly when you sequence a cancer genome, you get about, I don't know, from exome you have about 40,000 somatic mutations. From whole genome you can get something up to 8 million, depending on cancer type. And you want to basically do a recommendation system that will give you the flavor of those which would have the most impact on cancer development, prognosis, or origin, or etc. So you get basically a large matrix with 8 million mutations and then associated with features. These features can be anything from evolutionary conservation to the level of negative evolution in cancer, to splice size effects, etc. So you basically build a model that learns of all those features and that gives you the ones that would have the most impact on cancer development, let's say, for the sake of arguments. One thing that was one of my first projects when we applied this was a colon cancer project where we found that actually POL-E and POL-D1 mutations predisposed to colorectal projects. That was a work with Ian Tomlinson, Claire Hales, and Peter Donnelly, especially at the Wellcome Trust Center for Human Genetics. So when you get a set of mutations in these genes, you obviously want to know whether they segregate in the families. And when they do, you start looking into 3D structures of those proteins and whether those mutations specifically harm that 3D structure and whether you can get some biological explanation what it may do. So basically that's the map that you try to build here. This is a process which can be vastly automated with either classical machine learning approaches like supervector machines, etc., or with deep learning, and it's basically called mutation testing. So you have today millions of mutations and a lot of features. I'm not going to delve too much what would be, and then you train models. So basically you have, for each project you can use, I don't know, here we use 6.8 million benign variants against less than 500,000 of pathogenic variants, and then we build either binary or pentary model, whether you want to have the ACMG classification strictly built into the model. I mean, this is what is often done, and then today you have models that build on the model. So model is a prediction that kind of gauge the effect of mutation between 0 and 1. The closer to the 1 you get, the higher probability of mutation being pathogenic is. And now you can also build models from models. So you put together models, which is called ensemble learning, where you put together a couple of weaker models to build a strong model. So you have a large meta model that can predict whether the mutation is involved in cancer progression, origin, or any kind of relation to cancer. And then you want to know what kind of drugs actually may work on cancer. I mean, this is all built within the models. And that started with mutation testing. So obviously, I mean, we applied this approach to a bunch of projects. For me, being involved mostly in projects in colorectal cancer, renal papillary cancer, mesothelioma, and osteosarcoma, or bone tumors in general. Now, a lot of these things actually can be simplified. So now when we have enough X-ray structures, we can start to predict from DNA sequence what the structure would be, and whether, if you start mutating that structure, whether that would be a pathogenic change in relation to the structure's function. And now this is possible with second advancements. So when you take companies like Microsoft, Google, that you associated with, you know, word processor and whatever you need for daily basis. I mean, these are companies that heavily invest into biotech, basically. But biotech, I mean the AI models that can be used in pharmaceutical companies or anything which we call blue chip companies. And they have, like Microsoft, have Microsoft Genomics that have pipelines from data analysis to AI interpretation of the data, and Google has similar flavor of models that are called AlphaFold and AlphaGenome. AlphaFold is specifically what you can replace X-ray crystallography with, and AlphaGenome is now a new toy on the block. Tell it that can you annotate parts of the genome that are deeply intergenic, and you don't have enough, or you should not have enough data to really interpret whether, you know, chromosome 1 position 2,007,055, yeah, does it do anything or does it don't anything? So we have tools which are based on transformer deep learning technology that uses something which is called attention blocks. Attention blocks are basically now the key of interpretation in AI, and it started with seminal paper which was quite nicely called that all you need is attention. So this is now something which is a core of technology that help us to interpret human genome and allow us to generate billions of features that we can use to train models that can be used for interpretation. As I told you before, I mean, the features can be point mutation, can be copy number variants, can be anything which you can be, doesn't need to be really point, can be also interval list like promoter site, methylation site, intron extern structure site, anything that you can actually turn into a table. I mean, AI mostly works well in tables, so even if you have unstructured data, you need to turn into table first. The third sort of features which we can use is text, is human text. There's a lot of wealth knowledge on databases like CleanVar, or if you take the whole publication set of PubMed and try to analyze what is the information context of it in relation to specific mutation. You have text which you chopped into larger little bits and then feed you into your graphic card of a computer and let it crunch it for a while. So you can basically build models from all these sources of information, and it will be this sort of attention block structure. And the nice thing what you can do is now you can use the large language models like ChatGPT or Llama or anything that you use on daily basis to interrogate those data. I want to know all mutations which hit, say, KRAS exon 1, and I want to know all pathogenicity interpretation that is based on all this knowledge that I feed into these large language models. And it surprisingly doesn't take much. It takes a computer that has, I would say, our computer which we built specifically for this one has only 4 graphic cards, so you don't need really a large data center to build for millions to do this, and pretty much 1 terabyte of RAM is pretty much enough. So it's not a pocket computer, but it's nothing like a large data center that you need to do this to interrogate mutations. Now, this is applicable for cancers where you have solid data on mutations, which is not always the case. Colorectal cancer is a good case for this. I mean, breast cancer is a good case for this. Renal papillaries are a good case for this. But I dealt a lot with bone tumors like osteosarcomas, and these are very complex tumor types, especially when it comes to copy number data. I mean, these are one of the most shattered, broken, and then mixed up together tumor types that exist. I mean, on the contrary, POL-E and POL-D1 colorectal cancer or endometrial cancers, these are hypermutated as well, but they are mostly point mutations which these tumors acquire. I mean, osteosarcs are massively rearranged mutations, and finding a key mutation or key gene that would be kind of associated to majority of cases is literally impossible. So what you can do in these cases, you can train AI to look for patterns. So you are not interested in what kind of particular mutation caused that patient, that cancer, and you want to see some pattern which you can associate with treatment. For instance, I mean, you have mutation signatures, which we have now cataloged. I mean, this is version 2. I think now we are getting version 4 that have like 64 specific patterns. I mean, this is nothing more than a histogram of mutation frequency across cancer genome in trinucleotide context. So it's called 96 channel signature. So you take all mutations, you break them into 3 nucleotides, then you do the histogram, and then you look for association. And you can quite nicely associate that osteosarcs would or should be susceptible, for instance, to PARP inhibition. And with my German colleagues, Germany has very nice, actually, a project called INFORM, that is for pediatric patients, specifically tailored, that do not react to standard line of therapy. So then it's pretty personalized, and then a large set of patients within that program are osteosarcs. So we also published that, and that actually triggered a very lively discussion, because for osteosarcoma, since the introduction of chemo in the 80s, I mean, there was not really much of a cure that would actually cure the rest of the patients. So roughly half of patients responds to chemo and half don't. So what do you do with those that do not? And PARP seems to work a little bit. I mean, there are now companies trying to harvest this in silico approach to predict whether a cancer will be specifically susceptible to PARP. Myriad Genetics does it very well for breast cancer, and I think that was the first in silico drug approved by FDA in the US. But there's also a Sophia Genetics that actually took the knowledge from Myriad and did just different machine learning approach to get the same thing. So they kind of scooped them out in this. Why I'm telling this, it is because more and more drugs which are now approved are specifically targeted for very personalized setting. So no longer you are going to get a very generalized drug that can be, like cure for everything. More often than not, it depends on the context, it depends on the cancer type, it depends on the cancer heterogeneity within the cancer, which I have not talked about, but we did a lot of research on that. And it depends on a lot of more context. And AI is actually a quite nice tool that gets you that context extracted if you have the data. This is the bright side. So if this is all, unicorns and rainbows, that's why it's not already happening. So let me tell you a little bit why this is not going to be the case in foreseeable future. It works very well if you have the data. That's how machine works. That's how ChatGPT works. If you ask it any question which there is no answer for, it will still give you answer. Whatever you run with ML, you will still get some answer, although it's not relevant. So the first key point that I want to raise here, that AI works only on what we call labeled data. So if you have annotated features for the genome or for the mutations or features that you are trying to predict, it works well. If you go deeply intergenic, like with Google Alpha genome, then the interpretation can be wobbly, depending how much evidence you have and how relevant or whether the evidence is of good quality. If the good quality is not good, then the prediction will be not good. That's the second point. This is what we called in AI seesaw, which means shit in, shit out. If you feed the model with bad data, the prediction is not going to be good. So if you don't have the data for mutations or regions that you are trying to predict, you are not going to get a prediction that is relevant to your needs. Third is the explainability. I mean, explainable AI is now what is a hot topic. And it's because a lot of deep learning algorithms is a black box. So you just pour the data and you get this patient is eligible for treatment and this patient is not. So why? The models doesn't tell. So only now we are trying to develop models that give you some sort of explainability. This patient is eligible for treatment because this and this and this is hard evidence in the data. Not because I'm a black box and I have decided so. Probably the last thing that I would like to explain, and that's for you, wet biologist, which I've been a long time ago, is that we need to get relevant information about cancer genome. We need to get relevant data that we can feed into these models. And they are not going to get, we are not going to get them out of the thin air. So you need to generate them and then we can feed them into models. If we don't have those data, the models won't work. So that's pretty much my message for today. And thank you for your time. I'm happy to take any.
Thank you very much, Michal, for your inspiring presentation. And what I noticed at the last point that thanks God wet lab experiments still be the source of knowledge for AI, so that's why cancer research is here. And we are running out of time for a little while, so probably respecting two other speakers, so we will go follow and we will leave the discussion, if you don't mind, for the coffee break. Okay, so the last presentation in this panel will be focused on data in international studies regarding childhood cancer, and it's my great honor to introduce you Dr. Eva Steliarova-Faucher, who is a distinguished scientist from a cancer surveillance branch of International Agency for Research on Cancer, IARC. And before she joined IARC, she worked at Slovak National Cancer Registry here in Slovakia. And throughout her career, she coordinated multiple international consortia of cancer registries and contributing significantly to global understanding, especially of childhood cancer incidence, outcomes, and prevention strategies. So please welcome Eva Steliarova.
Thank you. Good afternoon. I am honored to be here. Thank you for letting me introduce myself and for giving you some information about what we do at IARC, and also hopefully pass the message why data are important in research. So I will start with the beginnings. When I started my professional career in Department of Epidemiology of Tumors under the leadership of Docent Ivan Pleško, who was the founder of National Oncology Registry. He was a medical doctor and a visionary scientist who understood the power of information that can come out of data. And as there was no registry at that time, he started one. So one of the highlights of his career was this Atlas Výskytu schopných nádorov, published in 1989 by Slovak Academy of Sciences. And the other one, even though the photo is quite pixelized, but this was a very important event because he, with his team, of which I was part also, organized annual meeting of International Association of Cancer Registries in 1993, which was, which is a very, very big event celebrating the collaboration of population-based cancer registries. So now I work since many years in International Agency for Research of Cancer. This is a specialized institution of WHO, which was established in 1965 on the initiative of French public figures, supported by President de Gaulle of that time. This is the building where I started to work those years ago, and this is our new building into which we moved 3 years ago. And as you can see, we are now celebrating this year 60 years of existence of this international agency. The mission of the agency was and is to promote international collaboration to help cancer research and its prevention. So I work in cancer surveillance branch, which is itself one of the 4 pillars of the agency's mission, and I suppose you know this website that is developed in our branch, which provides information about cancer burden around the world. So, and this gives the agency a big visibility. The other important area of activities is GICR, Global Initiative for Cancer Registry Development, which is mostly focused on development of cancer registration in low and middle income countries. And we also produce this flagship publication, which is in cancer incidence in 5 continents, and this is the main source of the information on cancer burden around the world. We are now after 12th edition of this publication, and as you can see, Slovakia was eager contributor to this publication, which also certified the quality of data that was produced in Slovakia until recently, until 2010. As you can see, there were no data from Slovakia included in the latest volumes, so this is a gap that needs to be filled in. So now I will turn to childhood cancer. Childhood cancer is special, and I'm very happy that this meeting is happening on 24th of September, which is World Cancer Research Day, but it is also in the month that is month of childhood cancer awareness. So I will put on this golden ribbon because for me childhood cancer awareness month is every month. So I work mostly on childhood cancer data. This area or childhood cancer is specific because it covers young age. It is very different from the cancers in general. As you can see, the morphology types are quite different. Most adult cancers are carcinomas, while there is much more diversity in childhood cancer, despite of rarity of these conditions. And also, because childhood cancer is rare, the pool of advocates is also relatively smaller. So on the Global Cancer Observatory site, we can see the predictions or estimates of cancer incidence and mortality for all age groups, but also for children, because they are all included in these statistics. However, the presentation of these data is first not complete, because they do not include all the sources that we have on childhood cancer data, and also it's not presented according to the typical cancers that occur in childhood age. For example, if you look at 0 to 4, these are top 10 cancers, so we can see that one of the top is vagina, but we cannot see neuroblastoma, which is the most common tumor in infants. So the situation was like this for many years, but since 2018, there was the global initiative for childhood cancer, which was launched by WHO, and this was supported financially by St. Jude Children's Research Hospital, which and the overall goal of this global initiative is to attain a 60% survival of children with cancer by 2030 and save this way 1 million of lives. So the cure-all framework of the global initiative also acknowledges the importance of data. For example, as you can see, the monitoring and evaluation is one of the 4 pillars, and there is importance placed on data that are provided by cancer registries. So if we need to improve cancer survival up to 60%, we need to somehow measure this. But as you can see on this map, the data is not available in many places. This is the proportion of childhood population that is covered by cancer registries, population with cancer registries. And for example, in Africa, there is 5% of children that are covered by registry, which means that all the data that are reported, for example, for Africa, are based on 5% of coverage, which is hardly significant. So this situation needs to be improved. And so this is why the Global Initiative for Cancer Registry Development that I mentioned earlier, and St. Jude Global. We joined the forces and created a program that is called Child GICR, and this is focused on developing cancer registration specifically for childhood cancer because of the specific features that are typical for childhood cancer. There needs to be also specific approach to cancer registration. So in this collaboration we have 3 working streams. One is implementation in countries, education and research. And well, as mentioned, this is focused on development of registries where there is lack of data, so low and middle income countries. The point that we are quite proud of is the education program. We ran a masterclass in 2021 and educated 22 trainers who can help us to educate further people in childhood cancer registration. So by today there are still 18 trainers that are active and who helped us run 4 courses to more than 100 participants from 20 plus countries on specific topics on childhood cancer registration. And we are currently preparing impact evaluation of the whole program and looking at what we can do next. But we are also working with countries with high income level who are mostly concerned about the survivorship, because as survival of patients with childhood cancer improves over time, there are more and more survivors, and these are exposed to higher risk of various health issues, including second cancers. So here, as you can see, a comparison between general population and the population of survivors, the risk of second tumor is much higher. And so we have a study which is called Cancer Risk in Childhood Cancer Survivors, CRICS study, in which we try to look at, estimate the prevalence of childhood cancer survivors in Europe or elsewhere, wherever data is available, quantifying risk of second primary neoplasms, assessing determinants of this risk, and then also trying to develop guidelines for cancer registries, how to collect the data to allow production of these data of interest. So as you can see, this is the estimates of risk of second cancer for childhood cancer survivors, and we can see that compared to general population, there is almost 5 times higher risk of getting second cancer for the survivors, and also there is about 20 cancers per 100,000 more in survivors than in general population. So, and the important part is to realize that all this data, these results are based on data that are routinely collected in population-based cancer registries. Maybe not all registries collect the necessary information, but many do. And so this is the very useful use of cancer registries data, and also useful way to show the next way of development of registries that do not yet provide this data. So this was comparison with general population, and now we have with us Miroslava Makohusová, who is also the leader of childhood cancer registry in Slovakia. This is extract of a publication comparing the pediatric cancer registry and general cancer registries. What are the differences and what are the similarities, and especially stressing the complementarity and usefulness of both types of registries. And she will also look at comparison of different types of treatment on the risk of second primary tumors in those survivors, again based on routine data from cancer registries. Well, now we know that there is more and more data collected on patients in more and more countries, but it is more and more difficult to get those data for international studies. And I would like to stress that especially for childhood cancer, which is rare, and we need a lot of data because otherwise there is not possible to compare. There are many tumor types. In Slovakia, for example, 1 year of data might produce 160 cases. If we split them into 12 groups or 47 subgroups, there is almost no cases in each of them. So we need international collaboration, and we need those features in those rows in the data, the individual records. And it's more and more difficult to get them. We might get them, but we need a data transfer agreement, which takes months and months to sign. And we don't get all the data, full data. For example, date of birth. Well, I don't know why this is secret, because we need to give it everywhere, but not for research. So this is something that, well, hopefully with contribution from patients who should be interested in using their data for further research, and contribution from researchers, from policymakers, hopefully try to get back the data that we used to have to be able to produce useful results. So, yeah, so these are my points that I wanted to raise. As was mentioned already today, cancer does not respect borders, so we need international collaboration. And this is especially important for childhood cancer, which is a rare disease, so that we have enough data to do research with it. We need to put back Slovakia on the world map to get the data and to have them quality assessed and approved, so that we know on which which kind of level we need to act for reducing the burden of cancer. And the last point is government is important, institutions are important, the support is important, but in the end, I think that a lot of progress is done by individuals. So if there are individuals who are dedicated and who are interested and motivated and work hard, they should be supported, because they can help. So again, the photos are beautiful, new building, and thank you for your attention.
And we will have 3 more presentations. One is not coming, so we will.